Now I'd like to invite Dr. SAURAV Shukla. He's going to talk about the most important thing in DIR approach, the one which everybody struggles initially, how to do a adequate femoral release.
Hi, nice to be here, seeing friends after a long time, and it's good to connect with everybody. I've just talked about the femoral release, proximal femoral release in the DA. Now, one of the reasons why people are generally dissuaded is because of the complications associated with the DA. And they are basically periprosthetic fractures, or you have basically the stem gets out of the femoral head, femoral stem. And one of the, Mangini wrote a paper in which he showed that there have been periprosthetic fractures associated with DA, and the reason is that when you are putting a brooch inside, it can come out from the lateral side. So the primary goal to prevent this is to have an external rotation of the femur as well as pulling the femur up, so much so that the femur lies more towards the anterior rim of the acetabulum, right? And once that is done, then you can use longer handle retractors and brooches to do a safe broaching of the femur. So just a bit of applied anatomy, some slides would be in common. It's important while you have approached the proximal femur, it's important to know the reflections of various muscles. So you have on the medial side, the iliocapsularis, that has to be elevated from the medial side of the capsule. On the superior side, you will have the reflected head of rectus. That also has to be identified. And on the lateral side, you will have the gluteus medius and minimus. Once you have identified all these three places and you have put the retractors, you have taken up the capsule, the fat, then you release the capsule. Now the femoral, the capsule, the hip capsule has got three extensions to it. The anterior part is the most strongest. It is the iliofemoral one. The important thing while doing the DA is that on the superolateral side where the saddle area is, it is important to release the iliofemoral from that aspect, right? If you look on the inferior aspect, you have the pubofemoral. Again, it's important to release the pubofemoral right up to the lesser trochanter and just a bit posterior to it. Otherwise, it will be difficult for anybody to external rotate. And there's a third extension called as the ischiofemoral one, ligament, which is posterior. Now, normally this ligament is not released unless the hip has got a bit of coxa vara or if there is a greater trochanter overhanging. If that is the case, then sometimes you might have to extend the release a bit posterior for releasing the femur and pulling the femur up. Now, again, a small anatomy of it. So this is the normal anatomy of the proximal femur. If you note, the conjoined tendon, the piriformis and the obturator externals is very closely associated with the capsule. If if you go on the middle of the picture, you will find the capsule extends not only at the base of the trochanter, but actually it extends sometimes towards the flare of the trochanter. So it's important to go right up to the base of the neck and put your cautery on the base and walk that cautery towards the tip of the trochanter. If once you do that, only then you will be able to release that capsule completely. In this process, sometimes you might have to release the conjoined tendon. In some cases, you might have to further release the piriformis. But please be mindful, do not go posterior to the femoral neck, because if you are releasing the obturator externus, it can be done in very difficult or revision cases. But in normally primary cases, if you do that, we might in some cases get posterior subluxation of the femoral head. So please be mindful where the obturator externus is and carefully dissect that area. So once we have done we have taken the capsule out. If we see the saddle area again, just re-emphasizing, it's important to take the capsule away from the saddle area. Otherwise, it will be difficult to ventrally translate the femur in this area. And the goal is to bring the femur up. So what we do is we put the operated side on top of the unoperated side. That will give adduction, flexion, and a bit of external rotation. And once we have done that, we then identify the upper and the lower boundary of the femoral neck. We then release the pubofemoral ligament by going down from the 6 o'clock position to the lesser trochanter and just curve it more towards the posterior side a bit, right? And this is how it is done. And then we'll lift the femur away and above. And once that is done, we then identify the capsule where it lies between 12 o'clock and 11 o'clock position. So when you are taking either the knife or the cautery, you have to go right deep into the bone and be mindful that you do not cut the obturator externus, which lies posterior or about at 9 o'clock position away from the position of the femoral neck. So in most of the cases, you are able to achieve these releases by iliofemoral and pubofemoral ligament. But in some cases, as I said, where there is a coxa vara or trochanter overhang, you might have to release the posterior capsule. We have seen this slide. This is the normal one. And if this doesn't work, then we might have to cut the conjoint tendon and piriformis fossa, giving rise to a 270-degree capsular release. The only place where we might not release or we do not release is where the obturator externus lies. And the goal is to achieve a ventrally and externally rotated proximal femur. So the danger has already been said by Shubhankar. One is the posterior circumflex artery, that is the communicating artery between the medial and the lateral side, and the second side is the obturator externus. And we now know the paper about the femoral release, Chuktai's paper, in which he has suggested that we can cut everything apart from obturator externus. And one of the examples of CRO 1, which we have dealt, in which in this case it's important to use the image intensifier properly. We have to know where our femoral head is. We should know where the femoral neck is. We should ream where the acetabulum under the image intensifier. This is the flattened head which has come out, and this is the result. So if we are doing a proximal femoral release, it's essential for both the acetabulum and the femoral preparation. It's important to know the surgical anatomy, what we are cutting and what not to cut is important. And there is always a stepwise release. We have to cut capsulotomy in all of the cases, piriforms in small and almost never obturator externus. And avoid releasing anything which lies posterior to the superior part of the femoral neck. So I'd also take this occasion as a member of the committee to invite you guys for the IAA Con 2025, which is happening in Lucknow this year. Thank you very much, and I hope to see you soon here. Thank you very much.